Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our Conversation with Cancer Experts series, we have one of the most distinguished CML experts in the country, Dr. Michael Mauro, who's CML Program Director at Memorial Sloan Kettering Cancer Center, which needs no introduction. And we're really thrilled to have him. He's going to talk about how he uses a relatively new drug. It's been out there for a while now, but increasingly used, Asciminib, in his practice. Welcome, Michael.
Ravi, thank you for that kind introduction. Sure. So yes, how are we using Asciminib? So this kind of encapsulates the story of CML and TKI development. We really changed the way cancer is treated with TKI development, which are small molecule inhibitors of, in this case, an abnormal tyrosine kinase enzyme, or a switch, if you will, turned on in cells. Thing is, we knew that there were both what's called an active site or ATP binding site area in this enzyme that you could block to turn it off, as well as what's called a myristoyl pocket, which is an abnormality formed when this oncogene is created. And if you could target that, that would also be an effective way. So as you can see, it might have been a good combination therapy, but in essence, we've studied that. But we have this very good data both in later line and now in front line for this drug to be used as by itself for Ph positive CML and probably some roles in Ph positive leukemias in general that are still under development.
So what I'll do is I'll have you tell us about how this drug has slowly progressed through the
Yeah.
treatment paradigm. The first study, I think, was in later lines and led to the initial approval. Can you just give us a little overview about that study design?
Sure. As you know, as a prelude to this trial called the Assemble trial, Asciminib actually started in phase one development back in 2013, and there was a very long and nice broad study in phase one looking at different doses, different patient populations, kind of set this landscape for asciminib being effective in people with and without the mutations that we know about, and we established the dose and the safety. So right away, in the heavily pretreated or patients with multi-drug resistant intolerant CML, a randomized trial was appropriate. So the Assemble trial looked at patients who had had two or more medicines. They could have had certain mutations where, for example, asciminib or bosutinib might not both work. But think of it as resistant and intolerant CML and multiple treatments previously tried, a 2-to-1 randomization, and the ability to cross over, with the primary endpoint of getting people into a safe level of remission called an MMR.
So what was the top line results of the study?
So Assemble really showed that asciminib was both more effective and safer than bosutinib. We knew bosutinib was a very good drug, and when patients responded, they did well. But it's often hamstrung by toxicity, by liver enzyme elevations, by diarrhea. And asciminib comparatively really had very little of that, perhaps a bit more myelosuppression, but with an improvement in MMR rates and an ability to keep patients on treatment, the response was overall better and again, better tolerated. So both molecular response on the top in gray, the cytogenetic remission response, which would be in the white, transcripts above 1%, and the cumulative, good endpoints we're looking for, patients maintaining safe response over a prolonged period of time out to 96 weeks was really pretty obvious in favor of asciminib here.
And I understand that among the more resistant mutations, it has activity as well.
So yes, exactly. So that trial again had excluded T315I. So how did we arrive at the data for asciminib? Another class of TKI being able to treat this resistant mutation. So just to level set, T315I is a point mutation in the ATP binding pocket that blocks most of the other drugs from binding. Ponatinib or Clusig is another TKI that does work, but it has some tolerability issues. So in the phase one study, based on preclinical data, asciminib was tested. Interestingly, a higher dose was needed. Now, we typically use 80 milligrams total per day. Here, we're using a total of 400 milligrams total per day in split doses. But in a pretty tough population, if you look overall, cytogenetic remissions or BCR-ABL less than 1% in more than half, major molecular remission in about half, and deeper remissions as well. MR4, MR4.5, where the PCR level is low and even consistent with patients who have really an ideal response. was quite possible. Now, if you've already had ponatinib, the other drug that treats this mutation, your mechanisms of resistance and your disease may be tougher to treat, and the responses may be a little lower, obviously. So the stats look better for those that hadn't already had ponatinib. And even though the dose was 5 times higher, and this is maybe a different population, the adverse events weren't too different from the lower dose we used for patients without this mutation and the same dose we now use in the front line.
So obviously the drug has moved slowly into earlier lines of treatment. So the S2 escalate study, a little bit of a tongue twister there. Could you just tell us what they set out to do here?
Sure. Yeah. So everything's going to use that three-letter acronym ASC for asciminib. So the asked to escalate trial, sort of two questions here. They did have additional patients treated in frontline, but that's not the focus of this trial. Really, this was asking the question about what happens if you dose increase. I mentioned just a minute ago that asciminib is typically in non-mutated and newly diagnosed patients. We'll get to that in a moment were treated at this dose of 80 milligrams. And then this T315I population was treated at 200 milligrams twice a day. So the Escalate study said, let's look at patients in second line who aren't responding well enough. They're not in a major molecular remission. Give them asciminib. If they don't respond within a certain amount of time, they continue above 1% or without MMR, can escalate the dose. And that was an unanswered question, really, at the time of this trial.
So how did it fare?
Yeah, I think so. The top line here is patients in or maintaining PCR levels below 1%. So that's a cytogenetic remission, and that's very good. And we can see that there's some improvements for patients that don't have that. The real endpoint here was getting people into the safer level of remission called major molecular remission, or MMR. A CML patient in an MMR generally has a very low risk of progression and transformation. And you can see that if you start and then potentially use higher doses of asciminib, you're going to get an increasing fraction of patients into MMR, roughly 40%, then over 50%, and then almost 60% over a year's time. The difference between patients who are resistant or intolerant were not substantive, although intolerant patients often do a bit better. And you can see on the bottom that deeper molecular remissions were also occurring, including up to about 30% of patients into an MR4, which again is a deep remission threshold and the kind of response we're looking for when we start from scratch and we see patients responding optimally. So asciminib seems to be able to correct course if someone had missed their best response with their first line of therapy, and dose escalation is helpful.
Obviously, then it moved into frontline therapy a while ago now. So could you just give us a quick idea of what this design was?
Yeah, so a whirlwind tour of all the trials that started with ASC. So they ask for first trial. As you just said, Ravi, the front line is the next question. So this was a very well-designed trial. It looked at newly diagnosed CML, but the bar was high. We had 4 drugs approved at the time of the study. So how do you compare? This would probably be the best way. Assign a patient a therapy, an investigator-selected drug, after they've been diagnosed with CML. And then if they enter the trial, it's a randomization between either going ahead with that chosen therapy or asciminib. And the main endpoint here was, as in prior efforts, major molecular remission, the protective level of remission by 1 year. And because we had all 4 choices available to the investigators to choose from, we wanted to compare how asciminib did versus imatinib and how it did versus everybody, and even potentially how it might have done against the second generation inhibitors. And that's where the data breaks out.
And so how did it do?
So busy slide, but so if you start on the left here, this is asciminib versus everybody. So the major molecular remission was clearly better, and it seems to be continuing to stay better over time. You can see the delta there is pretty significant. It's roughly a 20% increase in major molecular response. If you look at the middle figure, so that's asciminib versus imatinib, which is still a very good drug, very safe, very used globally and even in the U.S. in a fairly good number of patients. Now we have even a greater than 20% improvement in major molecular remission. So it's a bit tighter on the right because the study wasn't powered to show the difference between asciminib and the second generation TKIs, but we knew we had to look at it. And I think that the trends are pretty encouraging there, that asciminib may be widening a gap over time for patients achieving and maintaining MMR, if they're treated with asciminib versus any of the second generation inhibitors, nilotinib, dasatinib, and bosutinib. So, and then on the bottom, we have the rates of deeper molecular remission. And much like some of the other data sets, once you get to an MMR, you're more likely to get into a deep remission, and it's improved with asciminib compared to anything else.
What about the Ascend study? What was that about?
So the Ascend study was a very good effort from our colleagues in Australia, which really got us earlier data using asciminib in the front line. This was a single arm phase 2 trial of patients getting asciminib with a very smart design to say asciminib should perform well and should perform fast. So if you respond early, you stay on the standard asciminib. If you don't respond early enough and you don't achieve an optimum milestone, you could either increase the dose or even add a combination approach. In the very beginning, we saw the figure of the B3 kinase, and that asciminib and other TKIs could work potentially in concert with each other, or even synergistically. So they looked at not only major molecular response, but early molecular response as well as major molecular response to kind of see the kinetics and the advantages of asciminib in the front line. And this was that available to us before the other trials were designed.
And how did this experience turn out?
Well, we were looking at this point, we were excited about the salvage capacity and the safety of asciminib, but this really showed us that we had probably something very good on our hands, that the major molecular response at 12 and 24 months, and then further down on the left here, the deeper molecular responses, were really hitting some levels we weren't able to see with our frontline use of second generation TKIs. And they might even be getting close to some of the results we saw when we tried to use ponatinib in the front line, although that trial had to be stopped due to safety. Um, the um, the actual responses at a time point versus the cumulative incidence are shown side by side. But overall, the data was pretty compelling that asciminib might be our best frontline option, and again, supported the frontline trials we just showed.
And you started out by saying that one could potentially combine drugs. So I guess this is what the fascination study set out to do.
Yeah, so this study based in Germany is looking at a combination approach. It looks at nilotinib, dasatinib, and imatinib. We don't have as much combination data with bosutinib or much, and it looked at it really had a couple of questions. One of them was, should we be emphasizing the ATP competitive or the older TKI, or should we be emphasizing the asciminib? As you can see, the doses of asciminib now are different, 20 milligrams, 40 milligrams. So this study was, at an earlier time point, it was saying, how much can asciminib add to our standard drugs? And had a similar approach to the Australian study. Look at milestones, and if someone at a very early time point doesn't have a deep remission, they could continue on the combination rather than view it as sort of an induction and maintenance approach. So I think the design was again focused on seeing what we saw with combination, and this is a very good question, and still not we don't have the final answers, but this trial was very helpful.
So what did it show, and what is this clinical impact of ASXL1 that is being studied here?
Right. So when we looked at this data, we saw that the combinations are probably favorable, especially as you follow patients over longer periods of time. If you ask about the ASXL1 mutation, what this study and others had discovered was that some patients had secondary myeloid mutations, such as ASXL1, that may hinder their ability to perform like other patients. The major molecular response rate and the failure rate, the molecular response rate may be lower and the failure rate may be higher um, um, in this ASXL1 mutated population. However, this study showed a significantly higher rate with those with an ASXL1 mutation, which is it's sort of answering a different question. It's actually because it was a combination study, it showed us the path that ASXL1, if you tried asciminib alone, you may have a higher failure rate. If you tried a combination, you actually might do better. So this has led the way to us sorting out what could be a vulnerability in patients who carry this ASXL1 mutation. They may not do as well treated with a single agent, but they actually may do better with a combination.
So how do you figure out whether the ASXL1 is within the CML clone or is it in the myeloid compartment outside of the CML clone?
That's a great question. When you sample a CML patient at diagnosis, you have probably overwhelmingly just a PH clone. And I think that's a great question. I think we believe it's probably potentially like what patients have clonal hematopoiesis, it may be in the background, and the BCR-ABL positive disease might have emerged, in that setting. So I suspect that's what we're dealing with. I don't think we view it as a separate population, although that question is a challenge in CML. When patients are treated well in reducing the BCR-ABL clone, they may be left with a damaged background hematopoietic compartment, which could contain, myelodysplastic changes even, or myeloid mutations such as ASXL1.
And so the combination, did it become more toxic?
It was tough. I think this study again was focused on lower doses of asciminib. In general, when we've looked at combinations of asciminib and our conventional TKIs, we generally see most of the toxicity of the conventional TKI, and it was not easy. You can see that it's a variety of different toxicities. Nothing significant in grade 3, 4, but lipase increase, for example, and metabolic changes, as well as hematopoietic, issues, including myelosuppression. They probably are enhanced a bit, and it may be due to the combination TKI use, especially early in diagnosis. So again, this is why I said the story is not complete. We're probably still figuring out what should we emphasize, the ATP competitive or the prior TKI? Should we be focusing on asciminib and maximizing that and just adding smaller doses of the conventional TKIs? And what's the best time to use it? Is it early? Is it late? To maximize the utility of this combination. But I think the ASXL1 message from this study was pretty clear that those patients may do better with combination.
So you did mention the different doses that have been tried in the different studies, but what are the nuances of routine administration of this drug for general practitioners?
So remember that there's two doses, but it's unlikely to right off the bat come into a need for the higher dose. The standard dose is either 40 milligrams twice a day or 80 milligrams once a day. The pharmacokinetics and the efficacy seem to be quite similar. It's taken on an empty stomach, so the once a day dosing is probably easier for patients. For those with the T315I mutation, the higher dose is really required, and that is split. Um, the key side effects of asciminib are pretty limited, and they tend to borrow from all the side effects we see with the class of BCR-ABL inhibitors. Monitoring the blood pressure, as we should be in all patients, and routine blood tests regularly, looking at their blood counts, and particularly the pancreas enzymes, not always because pancreatitis is a risk, but there may be some moderate elevations or elevations that could necessitate investigation for pancreatitis, needs to be followed. There aren't a lot of other major complications that can happen with asciminib. We see a rare hypersensitivity reaction and some general constitutional side effects, but it's very well tolerated. And I think with careful dosing and patient education and good monitoring, it can be very, very easy and very well tolerated.
So before we wind up, so where have you gravitated to using this? There are so many trials. How do you use this drug in your own practice?
Yeah, I'll say it. I kind of cheat when I give this answer because I'm apt to put patients on clinical trials, and we are still looking at, for example, asciminib in the front line with the very important question about what will the cure rate be in CML? Will we be able to get more patients to a point when they can think about what's called a treatment-free remission? Generally, after 3 years of treatment in the right patient who's in a deep remission, we don't know the answer to that. But I'm very hopeful because of the improved tolerability and maybe that this is a novel agent, a STAMP inhibitor, targeting the myristoyl pocket. So I'm using it in frontline outside of a trial. I do have a lot of folks on this trial, which is looking at some of the things we don't always see in our industry trials, such as long-term quality of life and the finish line, if you will, of treatment-free remission and cure. I use it in salvage. I think that the main discussion there was how does it compare against ponatinib, which is a very good drug, but has a fair bit of side effects and risks, particularly in the cardiovascular system, can drive hypertension as well. So figuring out what patient is appropriate for what drug, I tended to take in the approach of low risk, high yield, and a stepwise approach because CML is a chronic disease, and generally with caution, if you can stay one step ahead of it, you can take advantage of all these newer drugs. And lastly, we're not done. There are second generation allosteric inhibitors, drugs such as TERN-701. There's new generation ATP competitive drugs such as Enliven-001. There's other agents in development coming out from outside the US, olverembatinib, and TGRX, other STAMP and ATP competitive inhibitors. So look for all these newer drugs in the CML space in the coming months and years.
So, last question, is a treatment-free interval for you now the goal of care, or is it for select patients?
I think it's a discussion for every patient. Nothing better than telling a patient who's starting with chemotherapy that our goal of treatment is a cure, which would be a treatment-free remission treatment that leads to successful discontinuation. Is it required? No, because the quality of life on a well-tolerated drug can be very high, and honestly, not everybody gets to eligibility for TFR. And at this point, we're only about 50% successful. So we have some more work to do. And yes, it should be a goal of therapy, but I reassure my patients that people can live well with CML and live a normal life based on data that we've generated now years ago.
Well, I really want to thank you very much for taking the time for educating our audience about this rapidly evolving area. I think this is a disease that you have made all oncologists proud with what you've done. Certainly a prototype of a chronic disease, but I think probably increasingly a curable malignancy. And I hope I can turn to you in the future to tell us more about things as they evolve and you get to even greater rates of cure.
Well, thanks for having me. And I'm glad I've been able to be part of this great story.
Or you certainly have even led it. Thanks a lot.